Welcome to Medscape. I'm Dr. Andrew Wilner, and I'm here today with Dr. Robert Gross. Dr. Gross is a neurosurgeon and holds the Henry Rutgers Chair at Robert Wood Johnson and New Jersey Medical School at Rutgers. Dr. Gross recently presented his research at the American Epilepsy Society. His abstract was titled Stereotactic Laser Ablation for Mesial Temporal Lobe Epilepsy, SLATE Study, a prospective single-arm multicenter study. Welcome, Dr. Robert Gross.
Thank you. My pleasure to be here.
Just to set the stage, we know that epilepsy surgery is really the definitive treatment for people with intractable epilepsy. They've failed all the medications, and that surgery will be best. But there's still the question of which type of surgery. Where does laser ablation fit in?
All of the surgeries that we do for epilepsy, save neuromodulation therapies, are destructive surgeries. They involve removing a section of the brain that is our so-called epileptogenic focus, or disconnecting part of the brain, or removing a large area like a hemispherectomy. And so the goal of epilepsy surgery, for the most part, is to remove the hotspot, the epileptogenic zone. And we've been doing this for a century by opening up the skin, opening up the cranium, and physically getting down to the brain and actually removing that section of the brain. I would call that maximally invasive surgery. It's painful, it's long, the recovery from it takes a bit of time, you're out of work for a while, and there are complications associated with it. And for years, we've been attempting to find a more minimally invasive corridor into the brain to do exactly the same thing, to remove that epileptogenic focus. Ultimately, this led to approximately a decade ago, the advent of a laser technique that is just such a minimally invasive approach, where a small laser catheter is introduced into the brain that is about the size of a pen cartridge in your regular ballpoint pen. And through that catheter, we can pass a fiber optic down into the brain and heat the brain up to the temperature at which it essentially melts in a very discrete area, and guide that with the MRI scan, which actually can show us the heating of the brain, so that we can be sure that we're ablating, and that's the word we use for this, exactly the area we need to ablate, no more and no less. So that technique is called stereotactic laser ablation, also goes by the name LIT, or laser interstitial thermal therapy. That technique is much more minimally invasive, involves less brain destruction, involves not doing an open craniotomy, quick to recover from, return to work more quickly, and has, in many respects, not all, but many respects, replaced the procedures that we were doing for the last century.
Let me recap a little bit. All you have to do is drill a very small hole, put a catheter in, heat it up, and you have MRI. Now, normally MRI, you send the patient, they get it done, they come back. But in this case, you have MRI, which is live, right, in the OR. Is that correct?
That's correct.
So you can see what you're doing in terms of following the temperature. I guess when it turns red, it's too hot. And then you're done.
Yes, it sounds simple. It is a complicated procedure. It involves a different set of techniques than were typically used by an epilepsy surgeon. These so-called stereotactic techniques, where we have to introduce this catheter while not being able to see it directly. So we use the MRI scan to be able to see it and to plan how it gets in, and a CAT scan as well. So these are called stereotactic techniques, and it involves using a laser in a different way than we've even done for many decades. So it's a novel approach. It's complicated, but it's masterable and repeatable. And yes, it leads to patients going home essentially the next day in the vast majority of cases.
So the question is it as good as doing the traditional surgery? What did you find?
We and others have been using this technique for as long as a decade. Our center has been leading the way with the most cases, but there have been many cases that have been done now across the country and even across into Europe and Canada. And we'd been doing that in a non-clinical trial way and measuring our outcomes. But as we all know, that retrospective type of data doesn't necessarily give us the most accurate rates. We carried out a single arm prospective trial that was done in a very careful and controlled manner to find the true rate of success of this operation. Based on ours and others' data, we suspected that it wasn't quite as successful as doing, let's call it the maximal surgery or an anterior temporal lobectomy. But we figured it was safer because there were fewer complications. And what our research attempted to establish was whether beyond a statistical level of doubt, we had surpassed the level of effectiveness necessary, as well as the level of safety necessary for patients to feel it was worth the sacrifice of not having quite the effectiveness of doing an open, maximally invasive temporal lobectomy. And that's exactly what we found. If you look at the mean seizure reduction, it was actually 56% of patients that became free of disabling seizures when followed for a year without any loss of patients. And when we look at the confidence interval around that, because all data has a level of reliability associated with it, could actually be better than that, could be worse than that, but we wanted to surpass a level of 43% as far as the lower bound of effectiveness. And we could say that the 95% confidence interval was at 46%. So it could have been as bad as 46% based on the data, or it could have been as good as 60 some odd percent. And it was at least as good as 46%. And previous research has suggested that that's the level of effectiveness that a patient would be willing to endeavor to have this more minimally invasive procedure if it was safe. And it turned out to be safe to a reasonable degree. So that's what we found.
Well, I remember when I was on rounds at the Montreal Neurological Hospital, and somebody asked Dr. Rasmussen what was the key to successful epilepsy surgery, and his answer was to take out as much brain as possible. And certainly there's truth to that, but it does have a downside. So it sounds like this laser ablation technique is taking out as little as possible to preserve brain function and also make it a lot easier on the patient in terms of side effects and back to work time and comfort.
Yes, what you said is true. If we do a hemispherotomy or a hemispherectomy and remove the whole hemisphere, which we do in certain instances when it's a very widespread pathology, that would be the most effective thing to do. But there has to be a level at which you can whittle down the amount that you take to have just the amount necessary to remove the epileptogenic focus without taking a bit more. And in an anterior temporal lobectomy, which is the operation this would replace, and even in the more selective amygdalo-hippocampectomy, which in fact they started doing under Andre Olivier at the MNI, either one of those operations subjects more brain to risk that's actually not part of the epileptogenic focus, but it's just part of the approach. And we're specifically talking about medial temporal lobe epilepsy, something we haven't brought out yet. These are cases where there's mesial temporal sclerosis or scarring of the amygdala and hippocampus, which are down deep and hugging the middle of the brain. And so the laser approach allows us to get into that spot with a minimum, not none, but a minimum of tissue disruption. So we don't take any of that excess tissue, which is a large measure of what contributes to adverse neurocognitive, neuropsychological effects after surgery. And a further part of the data that we found from the study is that there was no change in cognitive function and language function and verbal learning and memory. That was a very important aspect of it. We're trying to make it so that patients don't have to give up something to get something.
Now, I remember reading, I know this wasn't your research per se, but that another minimally invasive approach was to use radiation.
So gamma knife surgery has been explored. In fact, after a similar start to laser, where it's tried in single centers, it was subjected to in fact, a randomized controlled trial of gamma knife radiosurgery versus temporal lobectomy, the so-called ROSE trial. And unfortunately, that did not hit its primary outcome measure in terms of effectiveness, although in the end, it was about similar in its effectiveness of laser ablation. But the opposite problem also accrued, and that was it was not a minimally invasive or destructive procedure with respect to neuropsychological outcomes. And there were adverse effects, including radiation necrosis, which beset the gamma knife surgery. It is still a technique that is used in a number of people's hands. I can think of in particular in Marseille, in France, but it never was able to take off after that failed randomized clinical trial here in the United States. Another downside of gamma knife surgery is that it takes 6 and up to 18 months before it has an effect on seizures. And sometimes the seizures get worse before they get better because you have to see that radiosurgical destruction or necrosis, whereas laser interstitial thermotherapy in its various forms is immediate.
Yeah, that's a big difference. I was just going to ask you, in your study, the outcome was, I believe, at 12 months. So are you going to continue to follow these patients to see what happens, say, at 5 years?
Yes, absolutely. Patients will continue to be followed. It's not as quite controlled when we follow them in these long-term follow-ups. Patients can be lost. In our center and other centers, we've followed patients long-term. There is an attrition rate even after temporal lobectomy. If you look 10 years out, the results are not as good as 1 year out or 2 years out. So we do expect some attrition in this. Epileptic brain is sometimes can reorganize, or you got enough to cause a temporary effect, but not a long-term effect. And so we do have to follow these patients. The good news is that after doing a minimally invasive procedure like this, we can actually sometimes follow it up again with, if you will, some cleanup. If we have not been technically perfect, what do you get in temporal lobectomy that you don't get in laser ablation? You get some lateral tissue. Well, some people need that lateral tissue taken. And so we can go back in and do an open temporal lobectomy on these patients afterwards if they are not seizure-free from the laser ablation. And in my group and the other groups, we've done that. In fact, we published a paper on this, and we are successful in approximately 50% of patients who have failed laser ablation and undergo a temporal lobectomy in making them seizure-free. And then sometimes just repeating the laser ablation, we can make them seizure-free as well.
Dr. Gross, this has been a very informative mini course on laser ablation. Is there anything you'd like to add before we close?
One of the impacts of more minimally invasive surgeries is our ability to bring epilepsy treatment and ultimately, in many cases, seizure freedom to a larger population of patients. So there are many patients that are just simply unwilling to undergo the craniotomy that it takes to do this in an open fashion, even in the more judicious approaches like a selective amygdalohippocampectomy. I sit in front of a patient and I tell them the alternative to this, and immediately the hand comes up, when I'm just have my mouth open. Don't even go there. That's not for me. And so we have to meet patients where they are, and there's a very high adoption rate by patients for this minimally invasive approach. Almost nobody that we see refuses this procedure. So it allows us to bring this to all those patients that would refuse surgery before. In the majority of cases, we'll make them seizure-free from this alone. But in a lot of cases, when people get a taste of this, even in the minority of cases where they're not seizure-free and they say, okay, well, what are we going to do next? And you say, well, we could do an open surgery, but you aren't interested in that. And many patients will say, well, you know what? I've had a taste of being seizure-free for a couple of years. Let's talk. So this really has opened up surgical treatment for patients that are medically refractory. It brings it to a far greater population of patients. And I think that is one of the chief victories from this type of surgery and this research.
Well, helping people with epilepsy, that's what it's all about.
I agree.
Dr. Robert Gross, I want to thank you for joining me on Medscape.
It's been my pleasure. Thank you very much.
I'm Dr. Andrew Wilner. See you next time.